Good morning, Hector.
Good morning.
Good morning, Dr. Alfonso.
Good morning.
So we're here at Oxford Exchange again on an early Friday morning, doing our usual blog about different topics that we see in dentistry so that we can really help other people who have questions about different topics that we see on a regular basis that our patients ask us about during the week. So Dr. Alfonso and I were having a discussion and say, what have you been seeing recently, and what is it that we could shed some light on that would help patients in a longer format on how to really answer the questions that they have about topics that we might not be able to cover that easily in 1 to 2 sentences. And this is certainly one of those topics, and the topic for today is resorption. So, resorption, it's interesting because I've been in practice for 30 years and have seen this increase over time, and Dr. Alfonso, being more right out of dental school, has learned about this from an academic standpoint and now seen it in private practice. So what I'd like to do today is talk a little bit about it, and we get the perspective from you, knowing more academically what's being taught today, and then my perspective of what I've been seeing in private practice. So when you talk to a patient about resorption, how does that conversation go typically?
Typically when we're talking about resorption, we're looking at a radiograph. So it's going to be something that you see when you take a radiograph of the tooth.
True.
And it's going to look like a dark area within the canal or the inside of the root of the tooth, or a part of the root of the tooth. And so when we see that and we start this conversation, we just kind of give a basic definition of what is resorption. And how we would define it is basically the tooth structure, like the hard tissue of the tooth, is kind of eating itself away, which forms that darkness that you see in the radiograph.
And what does the patient typically say when you tell them that?
They're like, why is it doing that?
Right.
Yeah.
What do you tell them then?
Well, what I explain is typically it's an inflammatory process. So it's different factors for whatever reason that has propagated this to start happening in the tooth. So we kind of talk about what could be the etiology, because whenever there's something that comes up like that, it's good to know what is causing it.
Mm-hmm.
So we talk about if they've ever had any trauma on the tooth, if they've have any caries or periodontal infections surrounding the tooth that could be propagating this type of process to start happening.
Mm-hmm.
And we can talk about their occlusion. If the tooth has heavy forces on it, that can also be a trigger. So there's a lot of different reasons why something like resorption can happen. So really when we see it initially on the radiograph, we kind of define what it is,
Mm-hmm.
figure out why it's there, and then the next step is talking about what we can do about it.
Yes, and I've had kind of the same conversation. When we see this, I would agree. Your point about you find it on a radiograph, what Dr. A is saying is, yes, the patient doesn't know it's there, right? You would have no idea it's there. So you could be walking around with resorption right now and have not a clue. And what's surprising to me is sometimes I see it and it's like, wow. Our response is kind of like, wow, looks horrible. Meaning that you can look at it and it can look like 3/4 of the root is gone. And the patient's like, I don't have a problem. And we're looking at the x-ray like, you could bite down on something, this tooth could break right off the gum line. And the truth is, it doesn't happen like that typically. So, do you have patients that come in with pain with resorption?
Sometimes, yeah. It can be asymptomatic where they don't feel anything, but sometimes they do. They
Yeah.
have that tenderness feeling in that tooth.
Yeah, and sometimes, they come in thinking they have a cavity, and you look at the x-ray, you're like, ooh, it's resorption. Which again, we just say the word resorption like it's a household word, and the point of this conversation is we want to bring it into your vernacular. Because if we're telling you have resorption and we're you're caught on your heels a little bit on what this is. This is a conversation, again, in long format, so that you can refer to this video and have a better idea. So far we've established that it's something that you typically don't feel. It's something that your dentist is going to see on an x-ray. You're not aware of it, and it's kind of like it's a chronic inflammatory process where the cells have gone a little haywire and they've started to destroy the tooth from the inside out, or sometimes from the outside in. Which brings up the next conversation about external versus internal resorption. So how would you describe that?
So external versus internal resorption, there's the two types of resorption. Internal resorption, when you look at the tooth, you see that it has that inner portion where the nerve lives, so the root canal, the canal. Mm-hmm. Internal resorption will typically stem from that area. So it starts from the inside of the root and then goes outwards. And external resorption starts from the outside. So you'll see it at the border of the root structure, kind of eating in through, going towards the inside of the tooth.
Okay. And so what would you rather have?
I would rather have internal.
True. Yeah. So external can be a little bit more difficult to treat. It's a lot more unpredictable.
Yeah, because what happens is if it's on the outside border of the tooth, that root structure, you're not really kind of going in through the middle of the tooth. You have that outside border that you need to take care of. So when treating it, you're not just kind of going straight in through the tooth. You got to take care of those areas as well, which can be a little bit more challenging.
Right, exactly. And I probably see more internal resorption. So before we get to treatment, let's talk about the most accepted etiology that we see. So what would you say is the most common cause of this?
I would say the most common cause is some sort of dental trauma to the tooth.
Yeah, for sure. So when we talk about dental trauma, can you be more specific on the scenarios that you see trauma causing this, that patients need to be aware of?
Mm-hmm. So typically if you have a concussion to the tooth, so it's some sort of injury to the tooth, so you got hit by a softball or you fell a certain way, and so that kind of impact on the tooth can cause damage to the tissues that triggers this inflammatory process. There's more extensive types of dental injuries where maybe you hit the tooth and it's moved a little bit from its position, or one of the worst ones could be if the tooth comes out, and that's called an avulsion. So that one, if the tooth comes out, the tooth is exposed to the environment, the bacteria involved in that, so it has a higher risk of experiencing something like resorption.
Right. And these are kind of practical scenarios that we could kind of unpack a little bit. So you've mentioned some new terms, a concussion to the tooth, and an avulsion, and everything in between, right? Yeah. So, a common concussion that I see is a mom with her baby, right? Playing with the baby, holding the baby like this, the baby goes back, and you hit your tooth, and you're like, oh, your first thought is, I just broke my tooth. And you look in the mirror, and it's like, oh, it's okay. That's a concussion. The baby's crying, they got a concussion to their head, and you have a concussion to your tooth. That is trauma that can cause resorption. Doesn't always cause resorption. I don't know what the percentage, do you know a percentage? At one time I heard it was as high as 50% if it's a pretty hard concussion, because it disrupts the blood flow to the tooth at the PDL level, around the tooth, the ligament around the tooth, and can disrupt blood flow in and out of the tooth, and certainly can cause a root canal. And in these cases, what would you tell the mom? She's calling up, she goes, and we get this call, Dr. A, it's Friday night, I just had a horrible situation, my baby just bucked his head back, and I just hit my tooth, and our patient said I just concussed my tooth. What do you tell them? What do you do?
So I would tell them they should come in and get that tooth evaluated, and we can take a
Friday night?
Ooh, Friday night. No. Friday night.
It's not an emergency.
It's not an emergency.
Right.
You're right.
So they could relax
a
little.
Relax and
but then it would be a good idea to see you the next week.
Yeah.
What would you do?
I would take an x-ray of it, take a look and see how it is, do a vitality testing, so that's another dental term, basically seeing how the nerve is doing within the tooth. And once we have those parameters of what it looks like on the x-ray, what it is test-wise, monitor it for a while and see if anything comes up in 2 weeks.
So you have a good baseline.
Exactly.
Yeah,
you need
it's
that
something you
baseline.
can compare it to.
Yeah.
And even if it tested non-vital that day, it doesn't mean that it needs a root canal. You test it again another 2 weeks, and like you say, you have a baseline information. And that was what was interesting to me, is yes, it's non-vital, let's do a root canal. That is inconclusive at that time because it's just in the middle of that trauma, the blood flow has been disrupted, but it could come back. So let's just take it a step further. What about if they've partially avulsed the tooth? Let's just say that they hit it, and this is another common scenario. I'll give you a different scenario in this case. It's your son fell down, hit his face on a concrete, you sit him up, it's bleeding around the base of the tooth, and the child says, I can't bite down, because now the tooth is moved, they can't close all the way together. What do you tell the mom then?
Is this a Friday night as well?
This is a Friday night.
It's a Friday night. So when something like that happens, the tooth is in a different position within the socket, so where the tooth lives, than what it was before. Ideally, if you can reposition the tooth within that area, within the socket, to get it to where it's supposed to be. Now, it could be uncomfortable, so if you're not able to do that, it's understandable. But the goal would be to get that tooth to be back in the correct position and give it the time throughout the weekend in that position. And then you come in on Monday, you get evaluated, and what the dentist is looking for is where that tooth is within the socket in the position, if it's in the correct position. And from there, radiographs, vitality testing, and the third thing that's different is possibly splinting the tooth. So that is attaching the tooth to the teeth that neighbor it to give it extra support.
Yeah. And one thing I would add to that is if you touch it and it's really loose, there's a possibility that it could be broken, underneath the gum line. So it's like if you touch it and you feel the whole thing is moving, that's a pretty good sign that it's partially avulsed. If you touch it and it's jiggling, it may be broken at that point. So I would say, moms, because you're probably going to be the ones that would do this, you would want to grab that tooth and just real fast move it back and use the other tooth next to it as a guide to where to put it and get it back in place as soon as you can. Because the truth is, again on a Friday night, even if you couldn't do that, by the time they get to us, it's a little bit too late because now blood clot has formed and we're not going to be able to push it back at that point. It'd be torture, grab this thing and try to put it. The best chance to put it back in place is right then. The other thing I would add to this too that we didn't talk about is in all those cases, whether it's partially avulsed or concussed, NSAIDs would be good to get in the body right away. So Aleve, Advil, at whatever dose is appropriate for that person. For an adult, we're talking about 800 milligrams. For a child, maybe 200 milligrams, depending on your size. And stay on that for 3 days, which is the heightened inflammatory stage. Because if we're dealing with inflammation, we want to try to cut that off in the beginning.
Absolutely.
So let's take the nightmare case. Let's talk about scenario where again, Friday night, and you get the call, and you don't know exactly why, but somebody calls you, the patient calls you, and it's the husband calling and say, hey, my wife just ran into the sliding glass door, thought it was actually open, was having a couple of martinis, and went to go out of the sliding glass door and hit the glass. This actually happened, right? And her tooth came out. What do you do then? They call you right for the sake of, just the scenario. They called you the second this tooth came out, and the husband's like on the line with you.
Okay, so best scenario is the fact that they're calling the second the tooth came out. So the first thing I would suggest is the tooth is out and it fell on the ground. Let's give that scenario.
Yeah.
Grab the tooth by the crown structure, so the part that you normally see of the tooth. Don't grab it by the long root structure, because you want to keep that structure sound. It has protective layers on it that you don't want to touch. I'm talking about those protective layers. Yes, it fell on the ground. Do not try to clean that tooth or scrub it, because you don't want to interfere with the cells that are on that tooth. And the best thing you can do is take that tooth, and if you can, put it back in. And that's the immediate thing that you can do, similar to what we've talked about when you get hit and the tooth is in a different position. You want to try to get it back in that socket to give it a chance to settle, and of course that blood clot is going to form around that as well. Let's say you're not able to do that. The second best thing that you can do is put the tooth in milk.
I've heard this, and this is what I was taught, and it is true still, is to put it in milk because it's a neutral solution and it's going to be solving to those cells that you say are so crucial, because this thing, the tooth, has kind of, let's just say, like live cells around it that we're not wanting to dry out. And this would be a scenario where you'd probably come in on a Friday night.
That would be pretty decent emergency to come in for.
It would be, and it's because if you saw this and you understood what to do, which you should do, yes, you have to put that right back in the socket right away. Get it all the way back and just push hard, right? Put it all the way back in place. And then what we have to do at that point is we would splint the tooth.
Absolutely, yeah.
And this would be a tooth that would need a root canal as well.
Most likely.
Yeah. And in the scenario where it's, knock on wood, it's happened to me twice, right? We actually, the patient, it was out of the mouth for a while. So, we had the tooth, we told them put it in milk. They came and they had the container of milk in the tooth. We actually did the root canal on the tooth because it was already out for so long. And then we got the tooth back in place and splinted it together. And let's talk about what happens down the road. What's the scenario? I mean, if this is this tooth going to work? I mean,
so if the tooth gets put back into the socket within an hour or so, it has better chances. But for that scenario, if it's been out for so long, even if it's been sitting in milk, its chances of keeping the vitality or keeping sustainability long-term decrease. Root canal is definitely the best way to kind of give it a little bit more push towards success. But long-term, because it's been exposed to the environment and it's had all this trauma put on it, it's a high chance that it'll have things like resorption happen.
And what type?
Typically, it's going to be an external resorption because
external.
That root surface, that external part of the tooth has been exposed.
Yeah.
So if that does happen, depending on the extent of how that resorption is happening, then we would see the success of keeping that tooth long term. So definitely for that kind of injury where the tooth comes out on an avulsion, the chances of keeping that tooth are decreased.
And typically you're looking at an implant down the road. So these are three kind of scary scenarios, but we started talking about resorption, and these are more extreme cases of resorption, and we talk about these because these things happen. It's good information for you to know. I think the bottom line is if your dentist mentions resorption, you have some talking points at which to understand and understand what to do next. And so the most common scenario that we see daily is we've diagnosed a resorption, and let's get back to a common scenario. What is the treatment for this? And let's just say it's internal resorption.
Internal resorption, the treatment would be a root canal. So a root canal would be able to go into the source because internal resorption is within that root canal system. It would go in and be able to clean up that resorbative tissue, the bad tissue that's living in that area, and clean that all up and take care of the nerve as well, to give that tooth a better chance.
Yeah, and so even though it's not, so before I even knew this, I would say, okay, you have some resorption. It can take a while before it actually causes discomfort. And when it causes discomfort, we can then take the nerve out. But what we've learned since is that the earlier you get that resorptive lesion out, physically remove it, the better chance you have at containing it. So that is what I would agree with, is do the root canal early. And true, it may not bother you for another 5 years, but if you could nip it in the bud, so to speak, there's a much better chance at keeping that tooth and not having an implant down the road. The other thing I've seen, Dr. A, and I don't know if you've seen this as well yet, is sometimes I'm looking on the x-ray and it looks like it could be decay or it could be resorption. Have you seen that?
Not so much, but that would be a confusing thing to look at.
You'll see it where I'm looking at it, and it typically is like in the cervical area, down by the gum line, in an area where you typically wouldn't see decay because it's below the contact point. And I'm looking at it like it's kind of fuzzy, it's nondescript, and I'll tell the hygienist, she'll look at it and may say, oh, they have some decay here, and I look at it and I go, looks like it could be resorption. And that's external resorption.
It's a cervical external resorption.
Yeah.
It has a name, yeah.
And what we do in those cases is I go in assuming it could be decay or resorption, and I physically go in there and remove it. So just like as if I were treating a cavity. And I know it's resorption when I get there, and I'm not finding that decay. I'm finding very vascular tissue, granulation tissue. And you start cleaning it out, and you know it's resorption when you get to it, but it doesn't matter. You have to treat it the same way, and that is you try to contain it. And in those cases, the difficulty of it is containing it below the gum line like that, especially because it's very vascular and it's hard to get it cleaned, but we can do that. And this is the other scenario where your dentist may tell you, this looks like it could be resorption, it could be a cavity, and you're like, don't you know the difference? Sometimes you don't until you get, it's a game time decision. But in either case, the treatment is the same. You have to go in there and contain it if you can contain it. Because sometimes you get in there and it's like, where do you stop, right? So I think that that covers a lot on this topic at a pretty in-depth level.